Good afternoon, everyone. I'm Dr. Patience Ashmanya. I'll be moderating this Zoom session. And we are going to look at the National Registry and why we need it. So our objectives today will be to have a chat about formulating or what is currently available about the registries in Uganda. And as you can when you think about it, the main objectives for these registries is that you can look at outcomes in both the perioperative period, the ICU patients that we care for. And also this would also help us to do quite a number of things, improve the quality of care that we provide to our patients, and can also be used as a research platform. So currently in Uganda, we have a few registries that are available. That is the perioperative registries, but they are majorly in individualized hospitals, and we have two sites that are currently using them, the ones that are known to me anyway. That is the Mbale Hospital and Mbara. We need to see if it's still ongoing. They could share their experiences and we'll see how that is going. And then we had an ICU registry started about maybe a year ago by the team of our panelists today. That is Dr. Arthur, Dr. Cornelius, Dr. Adam, and Dr. Fred Blamba, jointly with their IT specialist, Herbert. Now, we're going to have 3 talks from 3 distinguished guests. Arthur is unable to join us today. He sent his apologies, but the rest are keen enough and happy to fill in where Arthur should have taken on the role. So we have Dr. Cornelius Sendagire. He's a cardiac anesthesiologist at the Uganda Institute. He's also a lecturer in the Department of Anesthesia and Emergency Medicine, with keen interest in the perioperative and critical care research in low resource setting. Welcome, Cornel. And then we have Dr. Adam. He's an anesthesiologist, currently based in Eastern Uganda. He's also an honorary lecturer at Busitema University and a specialist at Mbale Regional Referral Hospital. He's passionate about perioperative care and teaching in the low-income, countries like ours. We thank you, Adam. And he's also currently pursuing a PhD at Queen Mary University of London, with research interest in surgical outcomes and improving access to healthcare, and also the use of healthcare data to drive quality improvement. And then we have our third panelist, who's going to be Herbert Kiwalea. Funny story, the picture that is on the posters is someone else. We'll get to see who the real Herbert is. If you look at the pictures, it's quite interesting. We apologize for that. He's a health informatics specialist, and he's basically involved in analyzing healthcare data, optimizing the healthcare services in Uganda, and this is in collaboration with, of course, the healthcare experts. He's been a key player in the developing of the ICU registry that is currently available, and also working hand in hand with the team in Mbale to kind of get their other registries as the perioperative registry up and running. He's an expert in gathering pertinent healthcare data, developing effective information systems and procedures, and also supplying healthcare providers with access to shared information. All right, so that's about it for our panelists. We're going to listen to a talk by Dr. Cornelius, which is implementation of National Intensive Care Registry in Uganda. Cornelius, I hand it over to you. You're welcome.
All right. Thank you very much, Pesh. So without further ado, I think I'll jump right in. I will simply go into how we actually implemented we have implemented the National Intensive Care Registry in Uganda. These are my disclosures, and none of them is really influencing this particular talk in terms of any payments. But I have to say that all the trials, all the studies that are listed here, the BREATHE trial, the ARISE network, are all using the registry platform. And I'm also part of the core group of the Intensive Care Registry of Uganda. So in a sense, that could create some bias in what I'm going to say, but there's not been any payment in that regard. So jumping right into it, critical illness in Uganda, we know that the burden is huge, but how much of it do we know actually? The biggest causes of this is, of course, trauma, obstetrics, and infections that lead to sepsis. We know that our patients are younger than those in high-income countries. And of course, the mortality is probably much higher. But the question we always have to ask is, do we know the full story? Do we actually understand the epidemiology all through the critical illness that we have in the country? And so ever since we had COVID-19 come into the country, one of the challenges that we've had is that the ICU capacity was limited. But over the couple of 2 years that we've had with COVID-19, we've had a huge surge of number of ICUs that are actually admitting critically ill patients, from 12 to nearly 30 functional ICUs to date. And this surge has also happened within the public sector. So it is very important that we try to understand what kind of care is being delivered, what kind of structures are in place that are providing the platform on which processes of care are being delivered. And so it is very vital that we understand that whether you have resources or not, being able to know how to use the resources you have is extremely important. And so no matter how many ICUs or ventilators or ICU resources you can amass, if you have a gap in terms of care, it's not going to amount to much. So we still, to an extent, have limited knowledge and understanding of critical illness epidemiology within our setting, Uganda, regarding the processes of care that include what people may consider in terms of ventilation, organ support in terms of vasopressor use, antibiotic therapies, and then other bundles of care that we do within the ICU. How much of that do we actually implement, and how much of that affects patient outcomes in our setting? And in a sense, to answer that question, one needs a fairly huge database on which this can be best, and that's where the ICU patient registry forms another cog in the wheel that helps to turn the quality of care of patients within our setting. So if we look at some of the benefits of registries, is that I mean, clinical quality registries have been used all over the world. We shall look at some of them, but they provide repositories for what one would consider routinely collected healthcare information that will be on the charts, will be in the files, and puts them into an electronic platform with the sole purpose of trying to improve safety and care for patients, as well as, of course, providing feedback to the team that is providing the care, and also looking for cost-effective ways of delivering this care. And so when you're looking at a registry, you're probably looking at three major components, and that is looking at the structure of the place that is providing the care. And then how is the care being done? What are the processes of care that are being implemented? And when the process of care are being implemented, what is the outcome of the patients in that unit? And so this succinctly summarizes what you can get out of the registry. So in terms of outcomes, you're looking at survivals, you're looking at events, you're looking at resource use, you're looking at morbidity. And you can clearly delineate the kind of patients that you're having being admitted in the ICU, for example. Then you're also looking at core outcome measures that can be patient-centered, things like hospital mortality and ICU mortality, and you can have standardized mortality rates to see exactly how different that is from your own ICU compared to what the standard is, and you can compare and see if you're having a higher mortality in your ICU for equally sick patients as compared to the ICUs in the country. And then things like length of stay, and then of course additional outcomes, because it's a registry, it can go on for a very long time, and that allows you to assess patients over a long period of time. So some of the registries that have been implemented, as we shall see, go beyond patients who are within the ICU, and they start way before patients enter ICU. But when you're starting to eat something, you want to start off with a small bite, because it is important that you're able to chew what you've bitten off. And one of those registries is the ICNAC. This is from the UK. It's the Intensive Care National Audit and Research Center. Has been in existence for 25 years. One would say Uganda may only soon be celebrating its 1-year existence of a semblance of a registry. So the ICNAC records patients who are potentially who have the potential to be critically ill patients, patients who are currently critically ill, and those who are previously critically ill. So it has over nearly 3 million patient records. And then, of course, because of the massiveness of the registry, there's so many studies that can go through the registry in terms of data collection. And that allows them to churn out as many papers as possible. And this is partly one reason that may explain why the UK was the leading country in terms of outputs of research. They have a massive structure in place that can allow them to track patients and monitor them and see how they're faring. And then, of course, the ANZICs, that's Australia and New Zealand, and then the BRIC registry is in Brazil, and that's more of a cloud-based registry that is implemented in a couple of ICUs in Brazil. And partly, when you look at some of the papers that are coming from the Brazilian registry in terms of critical care, Brazilians are one of the countries. It's one of the countries that produces a lot of critical care papers in the world today. If we look at the current registry that we are using, it is used in a couple of other countries, mostly low-middle income countries, all the way from Asia, and includes part of Africa, East Africa mostly, and then a bit of Southern Africa. In Uganda, it started in 2020, as we shall see. But when it started in Asia, it was largely through collaboration and for research, and mostly a spin-off from an ICU registry work in Sri Lanka, starting off with 9 countries in Asia and in Africa. Then, of course, it had to be adapted to each setting to make sure that the data being collected has a bit of specificity to the setting that in which it's being collected. And of course, it looked at both quantitative and qualitative approaches, but each of the countries has local ownership of their own data, and the centralized curation where all the ICUs feed into that country's own ownership or in terms of the server, which Herbert may talk about later. So the registry in Uganda was implemented in 2020 in the middle of COVID-19, and has enabled us to have a broad perspective of the patients that have been admitted ever since. As we shall see, some of the data that you can get out of the registry, and then it has provided a platform to be able to do research and quality improvement programs, as well as clinical trials, as we're going to see later on. It's a cloud-based registry, really, includes about 5 ICUs, and with over 700 critically ill patients that have been included. And then, of course, such a massive project requires a grant and funding, especially for data entry, but also to sustain and maintain the information within the country by paying for servers that will host all this data that is being gathered. So the important aspects of the registry is, number one, to map the availability of resources within the ICU. And then, of course, you want to be able to describe the population you have, as well as come up with context-specific hypotheses that can be tested within your setting. Then, of course, because of the existence of this registry, it can allow collaboration between Uganda, Kenya, Tanzania, and look at an East African perspective, or you can look at it at LMIC perspective. Then, of course, I've already mentioned the quality improvement programs and projects that may be implemented, and that feeds into policy decision making, and then, of course, establishing benchmark performance of different ICUs, as well as ICUs on a national or a more global perspective. And then, of course, that feeds into how you're going to use your resources. So the registry basically allows you to be able to do a lot of assessment of the setting and be able to improve it in the long run. So how did we come up to this? Well, it always starts off with willingness to participate. And this was mostly from those critical care specialists who are already in place and we're working to try and improve patient care. Of course, getting a national project coordinator is important, and then the registry is made up of a core data as well as a daily longitudinal data that is collected. And then, of course, obtaining approval, and we held a couple of meetings fortnightly in the initial start to be able to give us a boost in terms of implementation, and then they became monthly meetings. So to date, we have data collectors who are dedicated to this task, and this can be within part of the ICU, or they may be external to the ICU, but these are people who have a keen interest in critical care. In one of the ICUs, we use a final year medical students. Some use nurses, and some may use residents who are available to help collect the data. And of course, the data collectors have training online, and they're trained how to use a laptop or a tablet. And then, of course, the information can be derived from patient files, as well as the clinical team, depending on what question needs to be answered within the registry. And then, of course, quality assurance of the data by site leads on a weekly basis is also important. So there's a validation process that ensures data quality of what is being entered, both at site level and at the national level. So this is what the national level platform actually looks like. And you can see ICU admissions on the side there, and you can see those ones who are admitted as emergencies, as those ones who are admitted as non-emergency cases. But as you can see in our ICUs, we have mostly emergency admission. In other words, these are patients you did not plan to admit, but they come in as emergencies. And it seems that that's the prevalence of admission of the patients in the ICU indeed. And then, of course, on this side, you have mechanically ventilated patients within the first hour of admission. So you have mechanical ventilation and self-ventilation. And as you can see, most of the patients come into the ICU self-ventilating in the first hour, and then they may become mechanically ventilated over a couple of days. Antibiotics within the first hour, you can see that there are reasons for admission are there. So this one gives you generally the broad perspective of what is happening within Uganda. And some of these are some of the indicators or quality indicators of care that happen within the ICUs. And this has gone through processes of what we call the Delphi studies, and you get a couple of experts within LMICs, and they agree on what QI indicators should be used in a low resource setting. How feasible are they? How accurate are they? How reliable are they? And that's the question that is asked, and I think the publication will be coming out soon. But the foundation, of course, is ability to monitor the patients, and then the nursing staff to patient ratio, intensivist staffing and to bed ratio, and then as well as medical coverage at night. Then the quality impacts of that is going to be felt in some of the outcomes, mortality, length of stay, hospital length of stay, hospital-acquired infections, whether it is catheter-related or ventilator-associated. And then, of course, the care processes that I mentioned before include everything from number 1 to number 7 in the yellow column. And these can be part of bundles of care, but as you can see, some of them are pretty familiar. VTE, duration of mechanical ventilation, monitoring the RAS and the stress ulcer prophylaxis, as well as SATs and SBTs, and so on and so forth. So to summarize a bit of the data that was picked up from 2 ICUs at the very start of the registry, you can see that in terms of median age, we had a fairly older age than usual, but this was because the ICU, one of the ICUs, was actually admitting COVID patients, and so we know those patients who tended to be a lot older than the usual ICU patient, and that is why this age here looks a little old. But you can see that this is the kind of information you can actually get out of the registry in case you implement it, and this is just baseline analysis. A lot more can be done. In Kenya, on the other hand, this is some of the data that the Kenyans were able to get out of the registry from about seven ICUs in Kenya, with over 2,000 patients, looking at ICUs and HDUs, and they of course looked at the case mix. They looked at the processes of care, how many were ventilated and how many were not, and then of course looking at the outcomes. And that is just a summary of some of the data from our neighbors. To date, we have a couple of projects that are going to use the registry platform that I've shown earlier. And of course, one of them is by our own Dr. Arthur Kwizera through the ARISE network, that will be looking at oxygen therapies before ICU admission. And that will be looking at CPAP and high flow nasal oxygen in terms of preventing ICU admission, but also intubation. And then the BREEZE trial that is very similar to the ARISE trial is going to be conducted in Rwanda and other neighboring countries. And then we hope that in time we shall bring the BREEZE trial and the ARISE trial together to have some form of a meta-analysis at a patient level to see the impact of these 2 methods of oxygenation on patients. And of course, because they're both using the registry, it is very much possible to have data collection that is similar in both countries, even if it's not the same. And then of course, the study down here, out of pocket expenditures on patients is important, because we have patients admitted to the public ICUs and they end up spending a lot of money while they're admitted there, and we really don't know how much they're spending. In the private sector, it may be fairly clear because of the nature of the hospitals, but in the public sector, it's quite difficult to tell. So that's one of the studies that's going to be multinational, including Africa. And so if you have a registry implemented, it's easy to be part of this and to contribute the data that may transform care. And then, of course, the other thing that happens through the registry are PhD projects. One of them will be the Motivate ICU, where they'll be looking at modifiable targets to improve ventilation therapy in ICUs in low-middle income countries. So there's a lot of things that can be done with the registry. Some of the barriers, of course, that always exist include anxiety and mistrust from administrators, but we try to overcome this through approach from an association and not an individual, and this creates a lot more trust that perhaps this is something that is valuable. And then, of course, because of the pandemic, there was a lot of exhaustion in terms of how much data can be entered, but also the workload was huge, and so these were some of the challenges, to the extent that at some point the registry you had to enter only admission data, and you cannot enter the longitudinal data because of the amount of work you have to do. But data collectors were recruited separately from those who work, and these would be the people responsible for entering the data. Then, of course, the ethical approval process is usually a long and winded. Largely, the aspects that Herbert will ably discuss in terms of data safety and data management. But most of the registries around the globe receive a waiver of consent until such a point in time when a study is implemented in them, and then the study has to obtain its own approval process to use the registry to collect the data. And then, of course, we had issues of server crashing multiple times, but that was solved by moving to a more reliable service provider. Internet connectivity, as usual in low-income countries, can be a challenge, but tablets tend to work a lot better than PCs. But some institutions do use PCs, which is fine, but tablets can make it a lot easier. And then, of course, adaptation of the data collection platform for each setting, and each ICU can request an adaptation for itself. Of course, there's a limit to how much adaptation can be made, but it's important that you use terminologies that are familiar to the ICU, but also that are international and universally known. Then, of course, initial scarce interest is always an issue, but I guess this is why we're having a CME. So how would you like to get involved? I think we are going to provide a link for anyone who would like to be part of the registry, to be a site lead for their hospital, to get involved. You write your name, your contacts, and then we shall reach out to you through AAU to be involved in this study. Rather in this project. It is broad for all hospitals, public, PNFPs, and private. So I would like to acknowledge the great work done by all these people in trying to make this work. And I think the sky is the limit from this point onwards. So thank you very much. I'll hand you over back to Dr. Patience. Thank you.
Thank you, Cornelius. We shall probably reserve all the questions to the end of the talk. If you have any questions, please type them in the Q&A chat box. We shall resolve them later. So let's see. All right. I see Mary saying great work done. Yeah, thank you, Mary. So now we're going to listen from Adam, who's an honorary lecturer at Busitama University and also a specialist anesthesiologist at Mbale Regional Referral Hospital. Adam, I'm handing over to you. Thank you.
Okay, thanks very much, Patience. I hope that everyone can hear me.
Yes, I can hear you.
Great, so I'm going to talk about perioperative care, understanding perioperative care and why we need a national registry. Thank you, Cornell, for your introduction. And you'll talk about the ICU registry. As we talk about registries, a lot of components about how they run and people's fears and interests in them are very similar. And so we've chosen specifically to talk about both intensive care registries and perioperative care registries today to try and garner more interest, answer people's questions, get more people on board. Like Cornell, I have a lot of involvement in registries, information and research about surgical outcomes, but I don't have any specific conflict of interest for this talk. So this is a quote that always sticks in my mind, that if you can't measure it, then you can't improve it. And I think it rings particularly true with perioperative care. And I'm going to illustrate this with a little story. So I work in Mbale Regional Referral Hospital, and these pictures are just to keep you entertained for a bit. But we had a visit from the Ministry of Health, from the top management group from the Ministry of Health, let's say. and they visit the hospital, they go around all the wards, and they enter theatre. And of course, they have a lot of useful information to talk about and suggestions of how to improve care. But the thing that stuck in my head, particularly from this visit last year, was that one of the leaders was very surprised to hear that we did a lot of pediatric surgery, and in particular neonatal surgery. And on learning that we did a lot of neonatal surgery, the response was that we shouldn't be doing it, that this is a type of surgery that needs to be done in a specialist centre, and that all these patients should be referred to Kampala. Now, that sounds like a nice idea, but in reality, when we try and refer our patients to Kampala, at least 80% of them don't go. And that's not because they're not received by the teams in Kampala, it's because they just can't afford to travel to Kampala, they can't afford to live in Kampala, they can't afford to pay for food when they're there. And so it's just not a realistic option for them. So I think this misconception, all of these surgeries that are complicated but can be managed in regional centres, that this misconception that they should all go to Kampala is based largely out of a lack of information and a lack of data. And it doesn't surprise you, because if we look at these pictures, these are our medical records in a regional hospital. This is the reporting form from 1 month in 2020, when we, in theory, were reporting the number of surgeries that we did in that month back up to the Ministry of Health. And you can see that there are a large number of zeros in every single box. And so when you're fighting against these challenges with data and the right data being fed back, it makes you think that maybe another solution is needed. And this feeling is shared across Africa. The African Perioperative Research Group ran a Delphi process looking at the top 10 priorities for perioperative research in Africa. And at number 8 came the establishment of a minimum data set surgical registry. So this is not a feeling for only myself and only us in Uganda, but also countries across Africa. So I want to use a couple of examples to demonstrate how registries can be useful. And the first is from a country from outside Uganda, so this is Ethiopia. And there are lots of good stories from Ethiopia, including an initiative by their Ministry of Health, Saving Lives Through Safe Surgery. And they have focused in some areas on improving the care for surgical patients. So alongside that, a network was set up, a network for perioperative critical care, along with some other partners and the Ministry of Health, to pilot a registry in 4 referral level hospitals to see whether it was possible. Over a period of a year, they documented 1,748 surgical care episodes, and the information they were collecting looked at certain key performance indicators, both in terms of looking at demographics, the patients that were having surgery, the outcomes, but also some of the quality of care indicators, including the use of surgical safety checklists. And so this work has grown since then, and now key performance indicators related to surgical care are integrated into their national health management information system and reported at a national level. And so I think that's a good example of where registries and data related to surgery and safe surgery can be integrated at a national level. This logbook is probably familiar to a lot of you. Logbook. And I'm showing it because my second example of a registry is one that we use in Bali. The registries come in all shapes and sizes, and I will allude more to that later. But this is how we used to collect information in theatres. So every single operation is logged, including information about what the operation was and who the surgeon and anaesthesia provider were. So the difficulty with that paper logbook is it's challenging to understand and interpret the data. And so we decided to develop an electronic version of the logbook and try and implement it again in a pilot to see if we can make data entry electronic and therefore more easily accessible. In addition to that basic metrics, we use a certain admission criteria for our surgical high dependency unit. And so we used the ASOS surgical risk score, which again I'll mention a bit later, but we wanted to integrate this information into our theatre registry. So the electronic platform that we used is based on software that's open source and very commonly available. It's called DHIS2, and it's the same software platform that's used by the Ministry of Health to collect their aggregate data across the whole spectrum of disease in Uganda. And so it's a familiar platform to many people. We chose it because of a lot of its advantages, including the ability to integrate it with the Ministry of Health management information system in the future, the ability to use it on both tablets and on computers, and various other aspects that make it very suitable for this sort of work. So as you'll see from the next couple of slides, we thought that implementing an electronic registry would be very challenging, and we didn't have resources. That we're lucky that the ICU registry had a few more resources. So for this, we didn't have any resources. We're entirely reliant on the team on the ground to enter the data. So that's the medical officers and the interns who are involved in the surgery, who are normally responsible for entering data in the book. So we didn't want to create an additional burden for them. We wanted to just transition from paper-based to electronic logbooks to start with. So the information that we captured almost directly mirrored what was in the paper logbook. And so the patients that undergo surgery are registered in the system, and then every time they come to theatre, they have a limited amount of data captured about their surgery, including a theatre outcome. Now, one gap in the registry at the moment is that it doesn't track patients onto the wards and look at their hospital outcomes. But we have recently started, about a year ago, they've started a new COSEXA training program in Mbali, led by the surgeons. And so they're very interested in developing this registry further and in incorporating complications and outcomes data from the wards. Now, this slide looks a little bit complicated, but I think people's fear and our experience from implementing registries, people's fear is that data is going to be lost or stolen. We don't know who will have access to the data. People generally think it's a research project belonging to one person, and they're naturally suspicious about why you're collecting data. And so there are some aspects of the systems that we use and the way that we store our data that helps to allay some of those fears. Cornell already mentioned the idea of using associations to support the implementation, because people are naturally less worried about, and if a Mzungu like myself comes along and wants to start collecting data, we store our data on local servers, which is actually a requirement by law in Uganda, and so we use Renu as our host, and we try to use international standards for security and backup. But I won't talk more about that because I would like Herbert to mention that in a bit more detail later. So the other advantage about the DHIS2 platform is that it has its analytical tools built in, and so that allows everybody who has access to the system, each end user, to be able to run their own reports. And I think that's one of the strengths. Often we think about putting data into a database and we can only get it out if we have a statistician. But actually what we want is we want to be able to run some quick questions through the system and see what sort of information comes out. So I just asked a couple of questions this afternoon. So I wanted to know last year how many procedures we'd done in main theatres. So this excludes obstetric. We have a separate obstetric theatre. So there are a few, when it's very busy, a few obstetric cases get done, but this excludes most of our cesarean sections. So in 2021, we did 1,790 cases distributed across the different specialties, as you can see here. And so it took me about 3 minutes just to run this and get the data out. And then as another example, I was interested in the age ranges of patients that have surgery. And so you can see here the green and the blue columns are our pediatric patients. So we have about 30% pediatrics. And these are just examples of data that can be very easily extracted from the system. So I think that's also a very significant advantage when you're designing a system to ensure that the people who are entering data can access and use it. Another use that has become much more common is that our surgeons are required to produce reports on their surgery that they've done for their annual appraisals. And so because they're listed by name in the system, they can just run a report very easily and get distributions of cases and the different surgeries that they've done very easily. And the main surgeons in Bali all have access to the system and can therefore access it whenever they want. So those are two examples. I've talked a little bit about Ethiopia, and I've talked a bit about our slightly smaller registry in Bali. And now I want to talk a little bit more generally about registries, because they can be quite complex, and it depends a little bit on what you want to use the registry for. So something as simple as tracking outcomes of our surgical patients, you could have a data light registry just with simple outcomes. We're just looking at outcomes alone, so one process measure. But it can also go to the other end where you're using it for much more quality improvement, other projects, and it becomes data heavy with multiple outcomes and a lot more process data that's required. I think this data tree that I've borrowed from colleagues in South Africa summarizes it quite nicely. So you need a core minimum data set, a minimum data set which your registry sits on, that remains the same throughout any registry that's of a similar nature in the country or even internationally, so that you can easily compare basic data. But on top of that, you can have the flexibility to use the platform for any project-specific data, any research projects, and the resources you require and how much data you want to collect can vary depending on what it is you want to use your registry for. I'd mentioned briefly about the ASOS calculator. So we don't really have our surgical outcomes in across the country. And actually, if we want to improve on our surgical care everywhere, we really have to understand right down to the most remote district hospital or even health centre floors. And in some places, a lot more high-risk surgery takes place. If you looked at the outcomes from the patients that I was involved in, for example, in Bali, you'd probably see fairly poor outcomes. But I'd like to think that that's because the patients that I get involved in are the higher risk patients. So it's important for us to use a fairly simple and practical risk adjustment tool for us to calculate our post-op mortality rates. And the ASOS surgical risk calculator just looks at 6 readily available bits of information about the surgical patient, and is very simple to use and validated in our setting, as compared to some of the more complicated risk scoring systems that are in use for laparotomies, for example, in the UK or in the States. So the reality is that setting up a registry is complex and complicated. And so based on the back of the desire by clinicians in Africa to set up a registry platform and a registry data set, a Delphi process was run to try and define the data set and what it might include. But actually it was quite tricky. And so after a couple of rounds, we struggled to exclude many data points. And in the end, we had a third round of virtual meeting to discuss and think about how the data set would be used. So eventually we realized that we came to a consensus that what we were producing was not actually a minimum. It was more of a core data set because it also had some process measures, looks at post-op complications as well. So this paper is being submitted for publication, so it will be shared. We'll share it soon, and I'm certainly not the lead, so it's been led by the team in South Africa. But we have developed what we think is a data set that can be used. Now, interestingly, there are several projects to develop perioperative care registries happening at the moment in the world, and they don't all seem to be joined up. The G4 Alliance and the WHO are producing perioperative care registry platform, also probably based on DHIS2. But I think the key for us is that we, as a country, we should have joined up thinking, and we should want to be able to use our data to advocate for both improved care and better resources. So getting started is always the hardest step. And what we want to do is we want to just get started in as many sites as possible in Uganda, with a core set of data that allows us to understand what's happening and compare and identify areas where we can improve quality of care. There's a small challenge that I find in Uganda, which is that almost every single project, no matter how small, seems to require ethical approval. And they always like to take your $400 for every ethical approval that you submit. But to me, a registry is part of routine data collection and shouldn't be a separate research project. Now, if you come to use the data and you analyze it with specific research questions, or you want to implement interventions and then look at the changes in the data, then that's different. But just our routine data that looks at outcomes and tracks quality of care, to me, is just part of our routine data collection. But within this, we recognize that every facility is slightly different. If you have a registry in the Cancer Institute, you may want to collect slightly different information to the basic information you want to collect in a district hospital in Busolwe, for example. And so understanding the local setting and thinking about who enters the data and how it gets entered, and flexibility outside that minimum data set is very important. So what are my key messages from this? So I think tracking outcomes and surgical volumes using a registry can really help us to plan for our delivery of surgical care. As we slowly get our NSOAP, the National Surgical Obstetric and Anaesthesia Plan, off the ground, it would be really nice to think that we had some data that was driving decision making in that. We can identify areas for quality improvement by using risk-adjusted perioperative mortality rates. But of course, the extent of implementation depends on what resources are available in each site. As a minimum, the core data set should be standardized to allow comparison. Thank you very much.
Thank you, Adam. I think that was really, really informative. We shall have more participation from the participants after Herbert's talk. Yeah, so now we can probably go to, we can listen to our IT health analytics expert, Herbert, and see whether our data is safe, where it's going, and what is this cloud thing all about. You can educate us more on how this works exactly. Thank you.
All right, thanks, Patience. I hope you can all see my screen.
I can see the screen.
Okay, perfect. So today I would like to talk to you about the safety of our national registries, specifically how we protect our data on these two platforms, which is the Protect ICU and MDAS. So Protect ICU is a national ICU registry, like Cornell has already spoken about it, and has been implemented in several ICUs around the country with support from MORU, a research health network. Whereas MDAS, which stands for Mbale Digital Analytics System, which Dr. Adam has already spoken to you about, is a DHIS2 web-based platform that is currently used at Mbale Regional Referral Hospital for different specific ward admission registries. So these two registries are hosted here in our country as mandated by the Ministry of Health. The registries are hosted on our cloud servers at RENU. RENU is a research and education network here in Uganda that offers a variety of network solutions. So Yeah, so now I'm going to talk to you. The focus of this presentation basically is how we keep the patient data safe on these registries. So a robust healthcare data protection program goes beyond just the compliance to maybe like the Ministry of Health regulations. Yeah, so because protecting healthcare data against today's threats is nothing easy. It's a very difficult task. So healthcare providers must balance between protecting the patient's privacy while also delivering quality patient care and meeting the strict regulatory requirements set forth by the Ministry of Health and other regulations such as HIPAA. HIPAA is HIPAA. So that stands for Health Insurance Portability and Accountability Act. So it sets the standards for sensitive patient data protection, and this is what our registries abide by. It has guidelines for registries and other information systems that handle, use, or even transmit patient information. So the Ministry of Health actually requires that patient information is secure, accessible by only authorized persons, and also used for authorized purposes. But it is really up to each registry to determine what security measures to employ to achieve these objectives. So as a result of increasing regulatory requirements for healthcare data protection, our registries take a proactive approach to implementing the best practices for healthcare security. And as a result, we lower the risk of suffering costly data breaches. I'm going to go through some of the data protection best practices for our national registries, what we abide by. So we'll discuss the most important practices we employ to comply with the regulatory requirements in our country. So the first one I would like to talk to you about is restricting access to data. I think this is very important because implementing access controls bolsters healthcare data protection by restricting access to the patient information. So to ensure that only registries, to ensure that only like a registry specific site has access to their data, we employ access restrictions that require user authentication, ensuring that only authorized users have access to that protected data. So all our authentication methods require users to validate that they are in fact the person authorized to access certain data. So using validation methods such as information only known to the user, like a username and password or PIN number. So we are also currently exploring what is known as multi-factor authentication. And this will be integrated with MDAS, which is what Dr. Adam spoke to you already about. The next practice is encrypting the data. So there is a slide that Dr. Adam showed you that looked slightly complicated. So it showed you basically how the data is accessed by the end users. So encryption is one of the most useful data protection methods that we use for our registries. By encrypting the data in transit and at rest, healthcare providers our registries make it more difficult, basically ideally impossible, for attackers to decipher the patient information. So even if they gain access to the data, they have that extra step they have to take, which is deciphering this information. So all the data is encrypted both at rest and at transit. So the Ministry of Health and HIPAA offer recommendations, but don't specifically require our registries to implement data encryption methods. So instead, the rule leaves it up to us to determine what encryption methods and other measures necessary or appropriate. So we use what is known as SSL. SSL stands for Secure Socket Layer, which is a standard security technology for establishing an encrypted link between a server and a client. So basically between the end user and our servers, there is what is known as SSL. The next practice that we try and comply with is securing mobile devices. So increasingly, our registries utilize mobile devices in the course of data entry. So mobile device security alone entails a multitude of security measures. So enforcing, for example, enforcing use of strong passwords, encrypting the application data, educating the users on mobile device security best practices, requiring users to keep their devices updated with the latest application updates, among other things. So we take that very seriously. The next practice I would like to talk to you about, which is also one of the most important, is backing up data to a secure offsite location. So cyber attacks can expose sensitive patient information, but they can also compromise data integrity or even the availability. So ransomware, as an example, is a type of malicious software designed to block access to a computer system until a sum of money is paid. Yeah. So even a natural disaster impacting a data center can have disastrous consequences if the data is not properly backed up. So that is why frequent offsite data backups are recommended. So with strict controls for data encryption, access, and maybe even other practices, we ensure that these backups are secure. So offsite data backups are an essential component of disaster recovery. So lastly, and actually to me it's the most important, is educating the healthcare staff. So I think the human element remains one of the biggest threats actually to security across all industries, but particularly in the healthcare field. So simple human errors or even negligence can result in disastrous and expensive consequences for our registries. So security awareness training, actually, we hold these occasionally, and it equips the healthcare data entrant, yeah, with the requisite knowledge necessary for making smart decisions and using appropriate caution when handling the patient data. So I often have trainings with our data entrants across the different registries to make sure that we are on the same page with security and other things. So we have other practices to ensure data protection and maintain compliance with the Ministry of Health and other regulations, but really these are the most important ones that are the core. So on that note, I notice we are running out of time. I would like to sincerely appreciate your attention this evening and thank you for listening.
Thank you, Herbert. That was quite informative. A few things sounded like Greek, but we shall get there with time. Thank you. All right, so now we shall open this webinar up for a Q&A session. For those who would prefer to actively engage with our panelists, please raise your hand. We'll let you know when you can unmute and ask. Otherwise, we can use the Q&A session. I will start with a few questions. I know some have tried to answer them through the Q&A box, but I will still just echo them so that everyone is on the same page. We had a question asking about when we are starting a perioperative registry. And I think that must have been answered through Dr. Adam's talk. Adam, I think you have to answer the question from Mary live so that we can have more people get on the same page. So she asked, thank you, Adam. And then the question is, what process did you go through to get the hospital administration to accept this huge move from paper to paperless? Like the DH platform, where else is it being used? All right, over to you, Adam.
Thanks, Patience. So actually, our transition from paper to electronic was much easier than we ever expected. We thought there would be difficulties both from the administration and from the users themselves. And in the first week or two, certainly there were some people complaining, but now and after about a month, it became very routine to enter the data into the computer instead of in a book. I think the key here is that we are replacing paper entry with the electronic version, and we're not duplicating it. Unfortunately, when the Ministry of Health comes to visit, sometimes they try and suggest that we should use both. And that, of course, creates double the work for staff who are already overburdened. And so that becomes very difficult. In terms of the permission from the hospital administration, we just started with a pilot, one computer, and we collected the paper records as well to reassure them that data wasn't going to be lost. And then we had to make sure that the flow of information that the medical records department and therefore Ministry of Health needs is seamless and in fact easier. We use the same system on our neonatal unit in the hospital to track admissions and outcomes. And so there's a dashboard set up for the monthly reports for the medical records team. And we just send, okay, it's not me, but the team just sends them a WhatsApp picture of the dashboard at the end of the month so they can enter their data. So actually it's made their job much easier instead of having to come and sit and go through the logbooks. There was a question about where DHIS2 is used as well. So that same software is used in about 80 or 90 countries around the world. It's commonly used by Ministry of Health to collect aggregate data about their healthcare system. And Uganda is one of them. So all of the aggregate data about the number of children with malaria and pneumonia, the number of deliveries and the surgical data, outpatient data, it all gets entered into the same software, although it's of course installed on Ministry of Health servers and is a different program to the one that we use. But the software is the same, and so people are therefore familiar with it. And I think that sometimes makes it easier.
Thank you, Adam. Mary, you have your hand up. Please ask your question.
Thank you very much, Pesh. And it's very impressive how much work the guys in Bali gets done. And I feel like it's because their hospital is a little bit smaller and all, you know, your admin really trusts you. I know Peter has tried to change a bunch of things in Mulago Hospital. I just want to pick his mind and Cornell and anyone else on this call that might be more familiar with Mulago Hospital. Like, what do you think this would mean to try and get a perioperative registry started in Mulago Hospital? Thanks.
Thank you, Mary. Peter, Cornell, do you want to chip in?
I think Mary partly states a very crucial point regarding the complexity of the National Referral Hospital that Mulago is, and I think there definitely would be a challenge in that. However, I think most of the issues would lie around what Herbert has alluded to and ably elaborated on. Allaying the fears of the administration is usually very important, because naturally we don't even trust money that we don't see as human beings. We think the money that we see is our money, and the money out there that we don't see is not ours. So it's understandable that someone would be afraid of something like that. But in time, I think starting the way Mbale started, having a pilot study, or a pilot period of time where you try to see how feasible it is, if it is easily implementable, I think is important. And then, of course, the other important aspect is to go through the approval processes where you answer all the questions that are required by the administrators, so that they are aware of the security of the information that you have, but also highlighting the other registries that exist within the country, and one of them is Rheumatic Heart Disease Registry. And these are important. It's important to highlight precedents already set within the country to be able to convince the administrators of the benefit and the security of the registry that you have, despite the fears that they may have. That's my submission to that. Thank you.
Thank you, Cornelius. Peter, do you want to add something? Okay, I don't see Peter. All right. So we have another question from Dr. I think Fiona. So she's asking, question one, there are many existing data collection models in various hospitals. For example, the Med 360. Can such registries be incorporated in these? I think I'll leave that to Herbert to respond. I don't know, or anyone else. Really. Herbert?
Yeah, all right, thank you. So my discussion was focused on two platforms. One was Protect ICU, and the other was on MDAS, which is a DHIS2 web-based platform. Mm-hmm. So the beauty about one of them, which is DHIS2, the MDAS that I was talking about, is that you can incorporate any other registries or any other systems, any other healthcare systems into DHIS2. So you can actually use both and use it for data warehousing, what is known as data warehousing. So all the data comes into one place, and you have one single dashboard that gives you a summary of the data that has been entered. So it's very sophisticated, of course, but with the right human resource, you can always get it done with with integration, with system integration. It's possible.
All right, thank you, Herbert. And then question two, are there a required type or number of entries for the data that unless entered, such data is rejected or the model accepts less or more of the data? I don't understand that question. Fiona, do you want to formulate that maybe on a live rather than the chat? Dr. Fiona, are you there? Or if anyone has got what she's asking, please go ahead.
Maybe I can come in and see if I understand the question. So it may be a little bit about data validation, and so make sure that you enter the correct data. Whatever program you use can be set up to ensure the correct data. So for example, if you're entering the FiO2, someone might write 40% and another person might write 0.4. So these data entry systems can all have program rules entered to make sure that the quality and accuracy of the data that's entered is correct. I wonder if while I'm talking, I can also just make a very quick comment about Malago. I think the politics involved in all these registries is made much easier in a smaller centre, absolutely. But I had understood that a surgical registry was already implemented in Malago. So you may need to ask around and find a team is already there collecting this data. So I think the key is always about trying to create one system that's joined up and uses the same nomenclature for the same thing, so that the data can be shared easily. Herbert mentioned in a very smooth and simple way that all data can be integrated into DHIS2, but it's not quite as simple as that.
All right, thank you, Adam. And there's another question in the chat room, probably not a question, but I guess what she meant is how are surgeons, how can we get surgeons on board and not have this sound like it's an anesthesiologist kind of registry? But I think this was elaborated in Dr. Adam's talk, because he mentioned that there are surgeons that are particular, that are, you know, like say recorded on the registry, and they can easily follow up their data and the cases done, just to kind of push for like say during their assessments or reviews, they can easily show how much work has been done. So I think that might help. So I don't see any more questions, but I can just ask a few. This one is to Dr. Cornelius. Say the ICU registry, how do you get the time for such work, considering the heavy workload most of us have? And this is more so in the public sectors. And if anyone else joins this, work group, will they have any funding or financial support offered to have a data assistant or data collection or research assistant available to them?
Yeah, thank you. That's a very good question. So the way the registry works is that we have we obtain financial support from partners through grants. The current support we are getting is I think from the Wellcome Trust, and the truth is, of course, to get any form of grant, there must be demonstration of implementation that is already in existence. And this allows you, of course, to be able to pay the data collectors who are independent of the medical team in most instances. That makes it a lot easier for them to enter the data. Your job, for example, if you so choose to be part of this, your job as the site lead is to, on a weekly basis, you dedicate maybe a Friday or a Saturday or a Sunday, whichever is easy for you, to look at the information that has been entered and make sure that the data that has been entered is actually accurate. In that case, you can get in touch with the data entrants and talk to them about it. In the initial period, of course, the data collectors get training, and then they get guidance from the person who is working in the ICU or who is familiar with that registry. So yes, it is a lot of work on the part of the site lead, but there is a small remuneration that allows you to keep going. But also, when you look at the data that you have, let's say you collect for over 3 months, the registry platform itself starts to summarize some of this information for you. You start to see what is happening in the ICU. You start to see what is happening to the patients. And if that does not get you thinking on how to improve the care of the patients in the ICU, then the registry is probably not helping you at all. So I think down the road, as you keep using it, as you keep reviewing the platform every week, you start to see a pattern of care that is coming up and a pattern of outcome that is coming up, and that will help you to be able to answer pertinent questions, improve the care of the patients. At the same time, you're having either staff or non-medical staff who are helping you to enter this data. And in the long run, it's how you fit it into your time frame that will help improve the care that you have for the patients in your ICU. So I think it's a very it's an adventure and an endeavor that if you're working in an ICU, you need to be part of, because it will help you and your patients to be able to improve the care that they receive in the long run. Thank you.
Thank you, Cornelius. Fiona is finally on. Let me unmute. Please unmute and answer your question. To ask your question, sorry.
Okay, thank you very much. I couldn't speak the other time because I couldn't have access to the mute button. But then my question is that is there like a standard, say, data collection tool for such registries that you can say that this is the standard? Each hospital which needs to, say, develop a registry must use this standard. And in that standard, maybe they must input entries. For example, patient's age or name or something. Or is it a registry that anyone can formulate using the IT guys to collect whichever data, you know, that you can collect? So does it have must entries, like say patient name, age, and what? And then things to correct error, for example, like someone cannot enter something like percentage oxygen is 200%, something like that. So are there those cutoffs that enable the system to control for that, or whichever data is entirely dependent on the person entering the data?
Thank you, Fiona. Adam, do you want to further add some more information on that question?
Sure. And so let me answer the second question first. And so you can build in what we call program rules into the database, into the registry. So that allows you to make sure the data that's entered makes sense and is accurate. So that's very easy to do and is already implemented in both of the platforms. The second thing is that so we make a core data set by making some of the fields mandatory. But the reality, of course, internationally is that everybody has their own opinion. And so there's no standard data set that exists already for an ICU registry or for a perioperative care registry. However, as a country, with the ICU registry, we've kind of already started, and with the perioperative care registry, with this African perioperative research group Delphi process, we've tried to standardize the minimum and the core data set. And so some efforts have been made to try to standardize that.
Thank you, Adam. All right, so I have one question for Herbert. In a place where we have many people that can't easily do, say, pro bono work, how do we get health data analysts, specialists to help out in some of these areas where, for the most part, if they wanted to participate in most of this research, it's likely to be pro bono or something they do for the good of, you know, their care for the patients. Is there any way that we can get more people like you involved in this work at subsidized prices? Or, and anyway, are there many trained people in the IT that have this health data IT background kind of thing?
Yeah, thank you very much, Patience. So you're asking if we can get more of me at a subsidized price. First of all, I'm actually at a subsidized price already as we speak. So, so that's, yeah. But I think there are many people out there that actually have a background of information technology, but there, I think, very few have a keen interest in health informatics. Very soon I'll be actually doing my master's in health informatics at Makerere. I just really have an interest, no qualifications yet. So I think anybody with a background of information technology can actually support implementation of a registry. So it's something that one would, because in my field I notice it's, if you're motivated by money, it's very difficult to actually achieve anything. So I think you need to be motivated by the work you're going to do. And there are very few people out there. So, but me personally, I'm happy to help with implementation of any registry, because I'm already supported by a grant. So together with the team, Dr. Adam, Dr. Cornell, I'm happy to help with the implementation of any registries here in our country, Uganda. Thank you.
Thank you, Herbert. That's really helpful to know that there are more people like you. So this probably, I think, Adam, you've had more experience with the registry, especially the perioperative kind, or even the ICU written. So if a hospital participated in this data collection, do they still have access to the data collected, and who do you give access in that kind of scenario? Is it the health administrator or someone who's the lead that can easily transfer the rights to the hospital admin?
Thanks, Patience, and that's a very important question. So with the registry, this is hospital level data, and so the hospital owns the data in the same way that they own the paper medical records of those patients. And so if somebody else wanted to use that data, then we would need to get permission from through the site lead for that hospital. So for example, if I wanted to look at outcomes in ICUs across the whole country, then we would first get permission from all of the site leads. And if we wanted to take part in an international project, and so Kenya approached us and wanted to do some joint work, then again we would get permission through the site leads to take part in any national or international projects. For me, the key here is not that we send information to one person or to the Ministry of Health and we can never access it. Actually, to me, the most important thing is that you, as the clinician on the ground, can use the data to help you improve the care for your patients. And so both of these systems allow you as the individual to access the data. And I think that who has access will be determined by the site lead and the hospital team at the beginning. The nice thing is that you can give people different levels of permission. So somebody like an administrator could look at some of the outputs, the aggregate data, but they wouldn't be able to access any of the patient identifying data. So they would have no idea what data is linked to the patient's name, but they can still see the number of admissions and the outcomes. So there are ways to set up role-based accounts that help to give people access who need it, but not give them access to too much.
Thank you, Adam. That's really helpful. Do we have any more questions that we can respond to? I don't see any more questions, and it's been this has taken us about 88 minutes. We had planned to have it in an hour, but I think it was more engaging and something quite new and helpful to everyone. If we don't have any more questions, I think we can end this webinar. We thank you for participating, Dr. Adam, Dr. Cornell, and Herbert. Thank you. This has really been a nice webinar, and we hope we can join and have more data collected for the good of our patients. Thank you.
Thank you, too. Good evening.
Thank you very much.
Bye.